So in this module, we'll be talking about benign liver disorders. Before that, we'll talk about the anatomy of liver, which has assumed a lot of importance in the last few years. And lots of questions are being asked, not only in the MCQ exam, but also in your college exams. Also, one thing which I want to highlight here, that portal hypertension has already been covered in the upper GI hemorrhage module. So if you're searching for portal hypertension, please refer to the upper GI hemorrhage module for that topic. Now, the first thing which we need to discuss is the anatomy of the liver. Now, earlier it was thought that the falciform ligament divides the liver into left and right hemilivers, but that's not true. The actual division or the functional division of liver was done by Coinard. Coinard was a French surgeon who divided the liver into various segments. So, if we have to study the Coinard's classification, the first thing which we need to do, we need to divide the livers into left and right hemilivers. And this division is based on the Cantel's line. Now, the Cantel's line is the line joining the IVC groove to the medial edge of the gallbladder fossa, right? So, this is the Cantel's line, which is an imaginary line which connects the IVC groove to the gallbladder fossa, right? So this is your imaginary line which connects the IVC groove to the gallbladder fossa. This is known as the Cantel's line, and this divides the liver into left and right hemiliver. But this is an imaginary line. What is the structure which actually lies beneath this line? So the structure which lies beneath this line is known as the middle hepatic vein. So this is the middle hepatic vein which lies beneath this line, and it divides the liver into left and right hemilivers. Now, once we've done this much, we need to further subdivide the liver into various segments, right? So let me just teach you an easy trick to remember these segments. We'll start clockwise from the gallbladder fossa, right? We'll start clockwise from the gallbladder fossa. So this is 4A, 2, 3, 4B, 5, 6, 7, 8. So we know that there are 8 segments in the liver. So we start clockwise from the IVC groove. So instead of 4, just remember it as A. A means 1, right? A means 1. It's the first alphabet. So A, 2, 3, 4 are on the left side, and 5, 6, 7, 8 are on the right side. So this is how quickly you can draw a diagram mentally also, and you can answer most of the questions. Now let's focus our attention on the left side. The left hemiliver, you can see, is further divided into left lateral and left medial. So left lateral is 2 and 3, and left medial is 4A and 4B. And this division of left lateral and left medial is based on the left hepatic vein. This is the left hepatic vein, and the left hepatic vein lies beneath the falciform ligament. This lies beneath the falciform ligament. Right, so you can see here that the falciform ligament is actually towards the left side of the liver, right? Now also you can see that the left hemiliver is divided into superior and inferior. So the division of superior and inferior is based on the left portal vein tributary. So superior inferior is based on the left portal vein tributary, where 2 and 4A are superior and 3 and 4B are inferior. So this was regarding the left side. The right side is just the mirror image of the left side. So on the right side, instead of lateral and medial, right is anterior and posterior. So 6 and 7 are posterior and 5 and 8 are anterior. And this is based on the right hepatic vein. So this is the right hepatic vein, and 6 and 7 are right posterior, and 5 and 8 are right anterior. Similarly, superior and inferior division will be based on the right portal vein tributary. This is the right portal vein tributary which divides it into superior and inferior. So this is a quick way of dividing the liver into 8 segments. Now let's talk about this in detail, and let's understand what are the various questions which have been asked in the exam pertaining to this anatomy. So the first thing which was asked in the exam, which segments or which structures divide the liver, which structures divide liver into various segments. Right, so as per the diagram which I've drawn and what I've told you, the answer seems to be quite logical. The answer is going to be, it is the hepatic veins and the portal veins. Hepatic veins and the portal veins. But if you have to choose one answer, and that is what was asked in the INI-CET exam, if you have to choose one answer, then portal vein is the best answer, because in Gray's Anatomy, this is what is written, that Coinard initially based his division on the portal vein tributaries. So that is what you need to mark if you have to mark one answer. Otherwise, it is hepatic veins and portal veins. Now, the other thing is, how many sectors are there? How many major fissures? How many minor fissures? And how many sectors are there in the liver? These are the next three questions which we need to know. So the fissures, the major fissures are wherever the hepatic veins are, those are the major fissures. So we know there are three hepatic veins. You have the right, middle and the left hepatic vein. So you will have three major fissures in the liver. There are three major fissures in the liver. That is your right hepatic vein, your middle hepatic vein and your left hepatic vein. Okay. The minor fissures are formed by the portal vein tributary. So we know that there is right portal vein tributary, left portal vein, and there is a fissure of Gans. There is a minor fissure also known as fissure of Gans. So there are three minor fissures as well. Please remember this as well. There are three minor fissures also. And how many sectors are there? So you can see right posterior is one sector, right anterior is one sector, left medial is one sector, and left lateral is one sector. So there are four sectors in the liver. And this would be helpful for us when we talk about liver resection as well. Okay. So there are four sectors in the liver. You have right posterior, right anterior, left lateral, left medial. Right. So these were the questions which were asked regarding the anatomy of the liver. Few other questions which you need to know for the exam. One more is that segments 4B and 5, they form the gallbladder fossa. So segments 4B and 5 form the gallbladder fossa, and these are the two segments which are removed during radical cholecystectomy for gallbladder cancer. 4B and 5 form the GB fossa, and these are the ones which are removed during radical cholecystectomy. These are the ones which are removed during radical chole for GB cancer. So that's another question which has been asked in the exam. Another question which you should know about is that segment 7, this segment 7, that is the right posterior-superior segment. Right posterior-superior segment. This is also known as the bare area of the liver. This is the bare area of the liver. And because this is the bare area of the liver, what is the significance? The significance is that most commonly affected by amoebic liver abscesses. Most commonly affected by amoebic liver abscess. So that is the significance of segment 7, which you should know about as well for the exam. Now you also have a segment 1. Till now I haven't mentioned segment 1 at all, so I want you to know about segment 1 as well. Segment 1 is an independent segment, and segment 1 is also known as the caudate lobe. Segment 1 is also known as the caudate lobe. Now, where exactly is segment 1 present? So, to just orient you regarding segment 1, majority of the segment 1 lies towards the left of the inferior vena cava, right? So, this is the inferior vena cava. So, majority of the segment 1 lies towards the left of the inferior vena cava, right? Now, why is segment 1 an independent segment? Because it receives blood from both sides. It receives blood from both sides. It drains bile into both sides. That means right and left. But the peculiarity is the venous drainage. The venous drainage is directly into the IVC. Via short veins directly into the IVC, it drains its venous blood. And I'll tell you one significance of this in a couple of minutes' time, and that has also been asked in the exam. Now, caudate lobe, I told you that majority lies to the left of IVC. In fact, 50% of tissue encircles the IVC, and this is known as a caval ligament. This is written in the latest Sebastian, and this is something which you should know about. This is an update. Caval ligament is 50% of the caudate lobe or segment 1. It encircles the IVC, and that we call it as the caval ligament. And why is this important for us? This is important while mobilizing the liver. While mobilizing liver during resection, we need to know about this so that we don't cause unnecessary injury. Right? So this is important during liver resections. Now, segment 1 has further been subdivided into a segment 9 and a Spigelian lobe. Now, 2 or 3 points regarding segment 1, that is the surgical importance of segment 1, which you should know. Number 1, segment 1 is involved early. It is involved early in cholangiocarcinomas. This we'll talk about in detail when we talk about cholangiocarcinomas. And second is that in Budd-Chiari syndrome. What is Budd-Chiari syndrome? Again, this has been covered where I've covered portal hypertension. Budd-Chiari syndrome is hepatic venous outflow obstruction. It is hepatic venous outflow obstruction, right? So in hepatic venous outflow obstruction, the hepatic veins, there is obstruction there. So the entire liver is shriveled and undergoes cirrhosis. But in Budd-Chiari syndrome, segment 1 undergoes hypertrophy. Segment 1 undergoes hypertrophy. And why does it undergo hypertrophy? Because of the point which I mentioned here, because it has direct drainage into the IVC, right? This is not getting affected by this syndrome. It has direct drainage into IVC, venous drainage. That is why there is hypertrophy of segment 1 in Budd-Chiari syndrome, and this has also been asked in the exam. So this was regarding the surgical anatomy of the liver. And one more point which I want to cover here, again I'll cover it in the next module when I talk about liver resections. I want you to know about the Brisbane classification of liver resection. The Brisbane classification of liver resection. And if you remember this image, you can easily answer all questions regarding liver resection. So what all do we need to know about? We need to know about left hepatectomy. We need to know about right hepatectomy. Okay. So if we look here, left hepatectomy, you can see here, left side is 2, 3, 4A, 4B and right side is 5, 6, 7, 8. It is very evident from the image. So left hepatectomy will be 2, 3, 4A and 4B, and right would be 5, 6, 7, 8. Now, what about left trisectorectomy? Left trisectorectomy. and right trisectorectomy. These are the new terminologies in the Brisbane classification which you should know about. Left trisectorectomy earlier was known as extended left hepatectomy. And right trisectorectomy was earlier known as extended right hepatectomy. Okay, so let's look at left trisectorectomy. On the left side, I told you these sectors are 2 and 3 is one sector, 4A, 4B is one sector, 5 and 8 is one sector. So left trisectorectomy will be 2, 3, 4A, 4B and 5 and 8. This would be left trisectorectomy or extended left hepatectomy. And right trisectorectomy will be 6 and 7, 5 and 8 and 4A and 4B. That will be extended right or right trisectorectomy. So if you have to write here, left trisectorectomy will be 2, 3, 4A, 4B and 5 and 8. Okay. And right trisectorectomy will be 5, 6, 7, 8, 4A and 4B. Right, so these form the Brisbane classification of liver resection. I've already told you that in gallbladder cancer, what we are removing is segments 4B and 5. And these days, whenever we are doing resections, we are doing anatomical resections. We try to remove the segments rather than just roughly remove the liver. So this was regarding liver resection, which briefly I wanted you to know. Of course, in the next module, I'll show you a detailed clip and some points which can be asked in the exam as well regarding liver resection. Now, another thing which I want you to know in the anatomy is the liver pedicle. So at the hilum of the liver, you have the liver pedicle, and the liver pedicle is formed by 3 structures. The 3 structures being the portal vein. Portal vein is posterior. You have the common bile duct. Common bile duct is dextral, CBD, D for dextral, that means it's on the right, and the hepatic artery is on the left. This is hepatic artery, this is on the left, and this forms the Mickey Mouse sign when you see it on a duplex. Where else did we read about Mickey Mouse sign? Correct, in varicose veins at the saphenofemoral junction, there also on duplex you can see a Mickey Mouse sign. A similar Mickey Mouse sign you can see at the hilum as well, at the portal triad. This is also something which you should know about. Now, what is the significance of this liver pedicle? The significance of the liver pedicle is that this liver pedicle can be compressed. This can be compressed at foramen of Winslow. This can be compressed at foramen of Winslow. So this is known as Pringle's maneuver, and I will discuss Pringle's maneuver in detail regarding what is the significance of Pringle's maneuver when I talk about liver trauma in some time. So basically Pringle's maneuver helps us in controlling bleeding from the liver, and also we get to know the source of the bleeding. Okay, so we'll discuss this in detail, but you should know about the portal triad. Now, I also want you to know certain points which have been written in the latest Sebiston regarding the anatomy, and these points also can be asked in the exam. So the blood supply of the liver, 80% of the blood supply is by the portal vein and 20% is from the hepatic artery. The right hepatic artery is the larger artery and supplies majority of the liver. This is another point which you should know about. There's less variation in anatomy of the portal vein as compared to the biliary structures. So the portal vein can split into, normally what happens? It splits into right and left, right? And right further splits into right anterior and right posterior. But the most common variation in portal vein anatomy is called portal trifurcation. Portal trifurcation means that it splits directly into left, right anterior and right posterior. This is the most common variation in portal vein anatomy which you should know about. Okay. At the hilum, I also want you to know that the right portal triad has a shorter extrahepatic course. has a shorter extrahepatic course, that is 1 to 1.5 centimeters, whereas the left portal triad has a longer extrahepatic course, which is 3 to 4 centimeters, and this runs transversely at the base of segment 4, and this is known as the hilar plate. The importance of this is when we are doing resections for cholangiocarcinomas or we have to do anastomosis. That is the significance of knowing which one has a longer extrahepatic course, because it will become easier to carry out anastomosis there. So these were the points regarding the surgical anatomy of the liver which I wanted you to know. What exactly is the function of the liver? I'm sure all of us have been reading since first year. It's been covered in physiology, biochemistry. Just to recapitulate quickly, it helps in maintaining the core body temperature. It helps in pH balance, synthesis of clotting factors and glucose metabolism, bilirubin formation, drug and hormone metabolism, and removal of gut endotoxins. These are the prime principles or the prime functions of the liver which you should know about. Now, talking about the investigations which we need to do in liver. So investigations, you have the liver function tests which are there. Liver function tests are done. Ultrasound is the first imaging investigation which you will carry out, but the investigation of choice for liver disorders, the imaging investigation of choice for liver disorders is a triple phase CT. And we'll be talking about this triple phase CT in great detail as we talk about the individual conditions later on. Also, you need to know that there are various scoring systems which are there, which basically assess the functioning of the liver. And one such score is the Child-Pugh score. So this Child-Pugh score basically assesses the function of the liver and tells us how much function is remaining in the liver. And this also has a prognostic significance that when you do a liver resection, it also tells us about the risk of mortality or morbidity in that patient. Now, the Child-Pugh score is a super important score for your MCQ exams. You need to remember each and every detail. You need to know the parameters, you need to know the values, you need to know the scoring for the exam. So it is scored from 1 to 3 and there are 5 parameters: encephalopathy, ascites, bilirubin, albumin, and prothrombin time. So based on this, we can calculate the score, which can range from minimum score of 5 to maximum score of 15. So Child-Pugh A is score of 5 to 6, which is least severe disease. 7 to 9 is moderately severe, and 10 to 15 is most severe or a decompensated liver. So these points you should remember for the exam in detail. Another scoring system is the MELD score. MELD stands for Model for End-Stage Liver Disease Score, and the MELD score takes into account bilirubin, INR, creatinine, right? And like I told you, the MELD score not only tells us the function, but is also a prognostic score which tells us the mortality. If a patient is undergoing surgery, liver surgery, what is the risk of mortality in that patient? For children, we use the PELD score, the Pediatric End Liver Disease Score, which includes albumin, bilirubin, INR, growth failure, and age less than 1 year of age. These are the 5 parameters which are included for pediatric patients. Again, I'll be talking about these scores in detail when I talk about liver cancer in the next module. So let's talk about liver trauma now. Liver trauma, I've already spoken about this in the abdominal trauma module in the trauma section, but I would like to reinforce some of the points because it's an important topic for the exam. Now, liver we know is the second most common organ injured overall in the abdomen. Most common, is the spleen. Blunt injury is a more common cause of liver trauma, and higher mortality is there than penetrating trauma and blunt trauma. But you should also know it is the most common organ injured in penetrating trauma to the abdomen. So most common organ injured overall is spleen. Most common organ injured in blunt trauma is also spleen. Most common organ injured in penetrating trauma to the abdomen is liver. Okay. So liver trauma, as in other abdominal traumas, we assess by doing a quick FAST scan. FAST, you know, stands for Focus Assessment Sonogram in Trauma. Again, this has been covered in great detail in the abdominal trauma module. So for details, please go back to the abdominal trauma modules and learn about Focused Assessment Sonogram in Trauma. Now, the first thing which you should know, when should we suspect liver trauma? So when do we suspect liver trauma? We suspect liver trauma if there is injury to right upper abdomen, if there is injury to right upper abdomen, or there is fracture of 9 to 11th ribs on right side, or there is bruising over right chest wall, lower chest wall. These are the times when we need to suspect liver trauma. Now, if the patient is stable, we will do a CECT, but if the patient is unstable, we will carry out a FAST scan, which I've already told you about. Based on this, you have the liver injury grading. This is the liver injury grading. And if you remember your module on abdominal trauma, I told you that please remember splenic trauma grading. For all the other organs, we'll just talk about the differences. So grade 1 is the same as spleen. Grade 2 is also the same as spleen. Grade 3 is also the same as spleen. What is different is grade 4, 5 and 6. Grade 4 is parenchymal disruption involving 25 to 75% of the hepatic lobe or 1 to 3 choanard segments. I've already told you about the choanard segments. 5 is when there's laceration more than 75% of the hepatic lobe or more than 3 choanard segments, or there is vascular injury. That also comes under 5. And 6 is also different. 6 wasn't there in spleen. 6 is when there is a hepatic avulsion. So these are the various grades which are there. And as we discussed, grade 1, 2 and 3 are usually managed conservatively. Conservative management, we've discussed, that does not mean you dump them on the bed and forget about them. You will keep on monitoring these patients. You will do serial CT scans to see if the injury is progressing or not, but no active intervention is required. 4, 5 and 6 require exploration and management. So 4, 5 and 6 require exploration and management. Now, whenever we explore a patient with liver trauma, whenever we do an exploratory laparotomy in a patient with liver trauma, so there are certain P's when you come to liver trauma. So those P's are you push, plug, Pringles, and packing. These are the 4 P's which you need to remember in liver trauma. So you push that area, plug any bleeding area if it is there. Pringles is very, very important. This has been asked many times in the exam. We carry out a Pringles maneuver. I told you Pringles maneuver is when you press the hepatic pedicle at the foramen of Winslow. Pringles maneuver is when you press hepatic pedicle. When you press the hepatic pedicle at the foramen of Winslow. And hepatic pedicle we discussed has your portal vein, hepatic artery and common bile duct. So by pressing this, what is going to happen? If we press this, then bleeding from the liver can either reduce or it can remain the same. So if the bleeding from the liver reduces, then we know the cause is either portal vein or hepatic artery. But if it remains the same, then it is the hepatic veins which are the cause. So it can temporarily control the bleeding, and this can even be utilized during liver resections. When you're carrying out liver resections for cancer, you can do a Pringles to control the bleeding there as well. And B, it tells you about the source of bleeding as well. And one more thing which you should remember, that Pringles in one go, 15 minutes is maximum time you will do Pringles. Otherwise, there will be damage to the liver parenchyma. So maximum duration is going to be 15 minutes. That is also been written in Bailey and Sebastian, both. So in this video, you can see Pringles maneuver where the lesser sac is being opened, and at the foramen of Winslow, you take control of the hepatic pedicle. I've told you at the hepatic pedicle, you have the hepatic artery, portal vein, and the bile duct. And once you take control and once you compress this, you can temporarily control the bleeding, and you can also get to know where is the bleeding coming from. So that was the video regarding Pringles maneuver. Now after Pringles maneuver, if you notice that there's uncontrollable bleeding from the liver, the other way to control the bleeding is to pack the liver. And you can see here, this is how packing of the liver is done. Packing of the liver is done by first mobilizing the liver. So we know that you have the left and the right triangular ligaments which are attaching the liver with the diaphragm. So you cut those left and right triangular ligaments, and then the liver falls down from the diaphragm, and that's when you pack it. You pack it with mops, right? You can see that it has been packed with mops, and this packing can usually be kept in place for 24 to 48 hours, and we can re-explore after 24 to 48 hours. And because of the tamponading effect of the pack, the bleeding usually stops. So once we've taken care of the bleeding, once we know what is the trauma or what is the injury which is there, the management, the definitive management can be, if you have a laceration, you can repair it. You can repair a laceration. If there is a hepatic artery injury, you use 6-0-proline. We know that proline is used for vascular anastomosis. So for hepatic artery, we use a 6-0-proline to repair it. For portal vein, we use 5-0-proline to repair the portal vein. Also, angioembolization is being used. Angioembolization is also being used if there is bleeding from the liver. That is also being used to control the bleeding. The complications following liver trauma, there can be hematoma, there can be an abscess. So if there's hematoma and there's collection there, that can even give rise to an abscess. There can be biliary collection. Hepatic artery aneurysms post-trauma can be seen. AV fistulae can be seen, and there can be liver failure as well. So these are some of the complications which can occur following liver trauma as well. Two more problems which can occur following liver trauma or iatrogenic injury are hemobilia and bilhaemia, and those are also two topics from which sometimes questions are asked in the exam. So hemobilia is defined as bleeding from the biliary tree is called hemobilia, and it is usually arterial in nature. So this is very important for you to know that it is usually arterial in nature. And the etiology is either blunt or penetrating trauma to the liver, or it can even be iatrogenic injury can also give rise to hemobilia. Very important in hemobilia is the Quincke's triad. Quincke's triad has been asked many times in the exam. Quincke's triad is jaundice, upper GI hemorrhage, which is the most common presenting symptom, and it presents as melena. Melena, you know, is black or tarry stools. So this is the most common presentation, and pain is there. The investigation of choice is CT angiography. That is the investigation of choice, CT angiography. The management, majority of the times it is self-limiting. Majority of the times it is self-limiting. But embolization can be carried out. If it is not getting controlled, then embolization can be done and the bleeding can be stopped. The other term, and these two terms can be very confusing, so I want you to have clarity. Hemobilia is bleeding from the biliary tree. Bilhaemia is when bile enters directly into the bloodstream. That is bilirubemia. When bile enters into the bloodstream, this is usually between a fistula, between the vein and the biliary tree. So fistula between the vein and the biliary tree is the cause of this. And it occurs due to trauma or post-interventions. Interventions like PTBD can also give rise to this. Clinical features would be rapidly progressive jaundice, because bile is going into the bloodstream. There's going to be rapidly progressive jaundice. Investigation of choice has been asked in the exam is ERCP. ERCP we know is endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography. This I've covered in great detail in the gallbladder module. I've even shown you a video of ERCP being done. And the management is ERCP and stenting, or we embolize the fistula which is there. So this was regarding liver trauma and these two short topics which are frequently asked in the exam. Moving on to a very commonly asked question in the exam, and it's invariably a short note in all college exams, and that is liver abscess. Now, liver abscess is when there is an abscess inside the liver or infection inside the liver, and there are two main causes for this. The two main causes are amoebic liver abscess and pyogenic liver abscess. So let's talk about the differences between amoebic and pyogenic liver abscesses. First, let's talk about the organisms which are there. So the organisms for amoebic liver abscesses is Entamoeba histolytica. That is the organism which causes amoebic liver abscesses. And you know that Entamoeba histolytica, what would be the route of spread? What is the route of spread of Entamoeba histolytica? You know that these would be there in the bowel, the flask-shaped ulcers. You have flask-shaped ulcers of Entamoeba. Flask-shaped ulcers are there, and it travels along the portal vein. And it reaches into the liver. So it spreads along the portal vein. This question has also been asked. And one more thing which you need to know regarding portal vein is that portal vein has laminar flow towards the right side. Laminar flow towards right. Therefore, right-sided liver abscesses are more common. Right-sided amoebic liver abscesses. Amoebic liver abscess is more common. This question has also been asked. And most commonly it is segment 7, which is the bare area of the liver. This also I told you when I was talking about the anatomy of the liver. So pyogenic liver abscesses, in 40% of cases, these are polymicrobial infections. So there are multiple organisms which give rise to this. It's a polymicrobial infection. But there are certain one-liners which you should know, which have been asked previously in previous years in the exam. The most common organism overall responsible for pyogenic liver abscesses is E. coli. The most common in Asia is Klebsiella. So most common in children with chronic granulomatous disease is Staph aureus. Now, what is the route of spread for pyogenic liver abscesses? So for pyogenic liver abscesses, it is in the form of ascending cholangitis. Right? That means it is an infection in the biliary tree and it travels up and it involves the liver. So it can also occur if there is biliary obstruction. That can also trigger a pyogenic liver abscess. So you should know the difference in the route of spread of amoebic liver abscess, which is via the portal vein, and pyogenic liver abscess, which is in the form of ascending cholangitis. Now the other differences between these liver abscesses. So amoebic liver abscesses are usually solitary. Pyogenic liver abscesses, it is 50% solitary and 50% multiple. If we talk about the clinical features, so clinical features, patient is less toxic. patient is less toxic in an amoebic liver abscess, right? The chances of jaundice are low. Whereas in pyogenic liver abscesses, the patient is more toxic, more sick. There are chances of sepsis as well, and there can be jaundice also. Jaundice is more common than amoebic. Jaundice is more common than amoebic liver abscesses in pyogenic liver abscesses. One more thing which is written in the latest Sebastian which I want to highlight here is that amoebic liver abscesses commonly occur in pregnant patients. So a line written in Sebastian is that they are less during menstruation. The chances of amoebic liver abscess is less during menstruation, but there's more susceptibility during pregnancy. So that is one point which I wanted you to know about. Also, both these liver abscesses are more common in males as compared to females. More common in males as compared to females. Amoebic liver abscesses usually occur in the 3rd or the 4th decade of life, whereas pyogenic liver abscesses will occur more common in immunocompromised patients, and they occur beyond the 5th decade of life. They occur beyond the 5th decade of life, so that is another point which you should know about. Now, if we talk about the investigations, if we talk about blood investigations, then you should know that for pyogenic liver abscesses, ALP, increased alkaline phosphatase, is the most common abnormality which is seen. Also, there can be increased PT-INR, but increased alkaline phosphatase is the most common biochemical abnormality which is seen in blood. If we talk about amoebic liver abscesses, increase in PT-INR is the most common problem seen here. There can be increase in ALP also, but most common for amoebic is increased PT-INR, and most common for pyogenic is increased alkaline phosphatase. There is some bit of controversy here. Different books write different things, but this is what we are going to follow for the exam. Then in amoebic liver abscesses, you should know that serology for amoeba can be entamoeba histolytica can be positive, whereas in pyogenic liver abscesses, blood culture can be positive. Because there are higher chances of sepsis, blood culture can be positive in these patients. So CECT is the imaging investigation of choice which can detect both an amoebic and a pyogenic liver abscess. Of course, you can't make out the difference just based on CT, but there are certain other findings which you should know about, that in amoebic liver abscesses, you're going to get anchovy sauce pus. You will get anchovy sauce pus. So you know anchovies are very small fish, and when you grind them up, if you make a sauce out of them, it appears to be dark brownish in color. So that kind of pus is what you get in amoebic liver abscess. You get anchovy sauce pus if you aspirate it. Right? And one more thing which you need to know, that the pus which you get in amoebic liver abscesses, it is devoid of neutrophils. It is devoid of neutrophils. Okay. In pyogenic liver abscess, on the other hand, you have pus which is present and neutrophils will also be here. Neutrophils will be positive. How do we differentiate these two? So if you do a gallium scan or a technetium-99 scan, you will see increased uptake. You will see increased uptake in pyogenic liver abscesses. Because of neutrophils, whereas because there are no neutrophils in amoebic liver abscesses, you will not see an increased uptake on a gallium or a technetium-99 scan in an amoebic liver abscess. So this is also one more point of difference which you should know about between these two liver abscesses. Now, how do we manage amoebic and pyogenic liver abscess? That is another thing which is being asked quite frequently in the exam. First, let's talk about amoebic liver abscesses, right? So first, let's talk about amoebic liver abscesses. So amoebic liver abscesses, the first line of management is you start the patient on metronidazole. And this metronidazole is usually double strength. So normally 400 milligrams thrice a day is given. Here it is given 800 milligrams thrice a day. So metronidazole is started for the patient. Now, if patient is responding, then metronidazole will be continued for 2 to 3 weeks. In this patient, right? If the patient does not respond, or if there's secondary infection, then we need to aspirate the abscess or put in a pigtail catheter, right? So I've already told you about pigtail catheters in the module when I spoke about postoperative fever. I told you pigtail catheters are used for draining abscesses, so we can put in a pigtail catheter. So what are the other indications for aspiration or to put in a pigtail catheter in amoebic liver abscesses? The other indications are if abscess cavity is more than 5 centimeters in size, if you have an amoebic liver abscess in a pregnant patient, if there is impending rupture, if there's a left lobe liver abscess, left lobe liver abscesses are particularly dangerous because there is a slim chance that they might rupture into the pericardium, and that can be life-threatening. So that is why these are the indications when you need to aspirate or put in a pigtail catheter in an amoebic liver abscess, right? Couple of other points which I want you to know. If the patient has responded and you've started metronidazole after 2 to 3 weeks, then we give a 10-day course. After metronidazole, we give a 10-day course of diloxanide furoate. Which is a luminal amebicide. So please remember this 10-day course after metronidazole. This is a luminal amebicide which is given for 10 days after that. Also, if the patient is not responding to metronidazole, another tissue amebicide. If the patient is not responding to metronidazole, another tissue amebicide is chloroquine. So chloroquine can also be added in these patients. Now, another point which I want you to remember is that this is an amoebic liver abscess, or this is a liver abscess which you can see on CT, and you can see that this is a pigtail catheter. With which we can drain the liver abscess. Now, even when you've drained the liver abscess, you should know that radiological resolution of the cavity of the abscess can take as long as 6 months, right? So sometimes what happens these days, patients will get scans done on their own. So a lot of time you will be sitting in the OPD and the patient will already come with an ultrasound, CT, MRI, and they'll tell you the diagnosis. So similarly, what happens after treatment, these patients might do scans on their own and they might be surprised to see the cavity still there. So you have to explain to the patient that radiological resolution might take a long time. So don't be bothered about it. Clinically, if you're all right, we don't need to do anything for the cavity. It will gradually reduce in size. So this was the management of amoebic liver abscesses. Pyogenic liver abscess, on the other hand, we need to give these patients IV antibiotics. And we need to have a low threshold for aspiration. So aspiration and pigtail catheter. In any patient who's not responding, you will have a very low threshold to put this. You'll put it and That is the treatment then, IV antibiotics and aspiration of pigtail catheter. So this was about amoebic and pyogenic liver abscesses. It's a very, very important topic. The differences between the two are a constant short note for final year students. So please make a note of that. Now, before we talk about hydrated disease of the liver, I just wanted to show you an image, a picture which I had clicked in South Africa. So, like I told you, anchovies are very small fish, but this was in South Africa long time back when we had gone whale watching, and this whale was hardly 10 feet away from our boat. And the very interesting thing is that, we were sitting in a very small boat. It was just a 7 or 8 seater boat, and it was just wobbling in the sea. And all of us, by the end of the trip, we were vomiting. But at the same time, we were so amazed to see the whale that we were trying to get as many good pictures as we could. So, and yes, vomiting can also be a clinical feature of liver abscesses. Patient can have right upper quadrant pain, they can have fever, they can have vomiting as well. One final thing which I want you to know in liver abscesses, that liver abscess, especially amoebic liver abscesses, you should know that they can rupture. And the most common site of rupture, is the subdiaphragmatic space. This is the most common site of rupture. This question has been asked in the exam. The other sites where it can rupture are the peritoneal cavity, or it can rupture into the pleura, or it can rupture into the pericardium, which is quite rare, or there can be secondary infection. So these are the complications of amoebic liver abscess which you should know about. So moving on to hydrated disease of the liver. Hydrated disease is caused by Echinococcus granulosus, or rarely it is caused by Echinococcus multilocularis. Now, I'm sure Dr. Shivika has covered both of them in great detail in her microbiology lectures. Multilocularis, you need to know, also leads to malignant hydrated, because these can give rise to multiple hydrateds, and they can be multiseptate as well. So that is Echinococcus multilocularis, which can give rise to malignant hydrated. Now, you know the definitive host for Echinococcus, the definitive host, D for definitive, D for dog. Intermediate host is sheep. And man is the accidental intermediate host. So this question also you should know for the exam. Man is the accidental intermediate host. And why accidental intermediate host? Because if it affects man, the organism cannot propagate. It's a dead end for the organism. So accidental intermediate host is man. So these you should know about. Now, the most common organ which is affected is the liver, followed by the lungs. And the route of spread is going to be via the portal vein only. That is how the organism is going to come into the liver, and that is why liver is most commonly affected. Now, if we talk about the clinical features, so there is equal male to female incidence. So majority of the patients are asymptomatic. And the most common sign which you get is hepatomegaly. So if it is symptomatic, the most common sign with which the patient is going to present, or which when you examine the patient, that is going to be hepatomegaly. The initial investigation, we know for liver disorders, the initial investigation is going to be ultrasound. But mind you, the investigation of choice is CECT. The investigation of choice is a contrast enhanced CT scan. There is no confusion regarding this. Okay. Now, some confusion arose because the initial classification for hydrated disease was based on ultrasound. That was the Gharbee's classification. But Gharbee's is the old classification and the new classification is based on CT. That is why CT is the investigation of choice. This is the classification for hydrated disease. You should know that you have CE1. This is the new classification. CE1 or type 1 according to Gharbee's is a unilocular anechoic cyst. This is the active form. CE2 is multiseptate honeycomb-like cyst. So this question has been asked. CE2 is honeycomb appearance. CE2 is honeycomb appearance. This you should remember. This is also an active cyst. C3A is water lily sign when you have a detached membrane. So C3A is water lily sign. This also has been asked in the exam. C3A is water lily sign. C3B is a cyst with daughter cysts in a solid matrix. This is a transitional zone. CE4 is cyst with heterogeneous hyperechoic or hyperechoic contents. This is inactive. And CE5 is calcified wall. That is also an inactive or a dead cyst. So you should definitely know about CE2, that is honeycombing, and C3A and C5. These three you should remember for the exam, along with the images which I've shown here. In addition to this, if there's any doubt, then serology can be done. Serology can also be done to confirm the diagnosis if there's any doubt. The management of patients with hydrated disease of the liver. So all the treatment is done under the cover of albendazole. So we will start the patient on albendazole for at least a week, 10 days before we do any intervention. So all interventions will be done under the cover of albendazole. Now the first line of treatment for hydrated disease of the liver, is now called PAIR. What is PAIR? PAIR stands for percutaneous aspiration. Injection and reaspiration. So that is PAIR, that is the full form of PAIR, and I'll just tell you what exactly is done in PAIR. So to understand what is done in PAIR, let's go back to the microbiology. And in microbiology, you know that there is an ectocyst, right? You have an ectocyst, you have an endocyst, right? Endocyst is the one which gives rise to daughter cysts. Endocysts are the ones which give rise to daughter cysts. And outside this, you have the host reaction. This is called the pericyst. Right? So if I just have to label this green structure is the ectocyst. This is one of the layers of the hydrated cyst. The purple one is the endocyst, which gives rise to the daughter cysts. These are the daughter cysts. And the yellow one is the host reaction. This is the host reaction, also known as the pericyst. Okay, so this is not a true layer of the organism. Now, inside the endocyst, you have hydrated fluid. This bluish is hydrated fluid. Now, the significance of this hydrated fluid is that if this hydrated fluid leaks out into the circulation, it can give rise to anaphylaxis. There can be an anaphylactic reaction. So that is why we need to be very careful when we are dealing with hydrated disease. So PAIR, the first step is percutaneous aspiration. That means under ultrasound guidance, we are going to introduce a needle inside the cyst. And we aspirate all the hydrated fluid. The second step is injection. And what exactly are we injecting? We are injecting a scolicidal agent. We are injecting a scolicidal agent so that we can kill the organism. And the most commonly used scolicidal agent, the most commonly used is hypertonic saline. That is the most commonly used scolicidal agent. This has also been asked in the exam. The other scolicidal agents are ethanol, absolute alcohol, cetrimide solution, or mebendazole solution. So these are the various scolicidal agents. One question which was asked 4 or 5 years back in the exam, that is formalin is not a scolicidal agent. Formalin is not used as a scolicidal agent. This you should know about. This has been asked in the exam. So once you've injected, then we are going to carry out re-aspiration. So that is what is done in PEAR. Now, PEAR is the first line of treatment. So, of course, there have to be certain contraindications. So, what are the contraindications for PEAR? The contraindications for PEAR are a dead or a calcified cyst. We don't fiddle around with them. If it is a deep-seated or inaccessible cyst, if there is impending rupture, if there's impending rupture, if it's a multi-septate cyst, if there are multiple septae, then you can't aspirate entire thing. So multi-septate cyst, it is a contraindication. Mind you, multi-septate is a contraindication, not multiple cysts. If there is a multiple unilocular cyst, you can aspirate multiple of them. But multi-septate, if one cyst has multiple septae, then it is a contraindication. Right? Then extrahepatic cysts. Extrahepatic cysts are a contraindication. And if you have a cystobiliary communication, if there is a cystobiliary communication, that means when you aspirate first, if you aspirate and you get bile, that means the cyst is communicating with a bile duct. That is cystobiliary communication. So on aspiration, if you get bile, we need to stop the procedure. Why do we need to stop the procedure? Because injecting a scolicidal agent would cause chemical cholangitis. Would lead to chemical cholangitis, right? That is why we will stop if we aspirate bile. So if we cannot carry out PEAR, then we have to carry out surgery. And the various surgical options for hydrated disease are cystopericystectomy, where you remove the cyst along with the pericyst, cystopericystectomy. If there are multiple cysts in one lobe, we can even do liver resection. And capitonage. Capitonage is when you remove the cyst and you spirally suture the cavity. So these are the various surgical options which are available in hydrated disease. And I would like to share a very interesting case with you. I was in second year of my post-graduation, and we had a 14-year-old girl who had come to us with hepatomegaly, and her entire liver was studded with hydrated disease, right? The entire right side of the liver, there were at least 10 or 12 hydrated cysts in the liver. And you can see here, this is the floating membrane sign. So it was like this. You could see multiple hydrated cysts there. on the CT scan. So we gave her albendazole and she was taken up for surgery. We had to resect that portion. And I remember that whenever we do surgery for hydrated disease, these cysts appear as pearly white cysts. Okay, and we don't want any of the cysts to fall in the peritoneal cavity. So what do we do when we are doing surgery? We lined the abdominal wall with betadine soaked mops. And betadine, you know, is dark brown. So these mops were all dark brown and they were lining the cavity. And even if one small cyst was falling down, this pearly white cyst was easily made out against the background of that dark brown betadine, and we could pick it up and prevent any peritoneal spillage. So I remember this case because this was the first time I saw liver resection, and the right lobe was resected and the patient did fine. She did not have a recurrence following that surgery. So this was regarding the benign liver surgery module. I want to talk about some MCQs. The tumors I'll be covering in the next module. So MCQs, before I talk about MCQs for final year students, I've already told you anatomy of the liver, short note, differences between amoebic and pyogenic liver abscess, short note, and hydrated disease of the liver, short note. So these three short notes you should be ready with from this module. True and false regarding liver anatomy. There are 3 minor and 3 major fissures. This is true. The functional classification is based on portal veins and hepatic veins. This is true. And I told you if you have to choose one, you will mark portal veins. Segment 7 is the bare area of the liver. It is the posterior-superior segment. This is true. Right hepatic vein lies beneath the falciform ligament. This is false. It is the left hepatic vein. And segments 4A and 5 form the gallbladder fossa. This is false. This is 4B and 5. Which of the following is not an indication for aspiration in a patient with suspected amoebic liver abscess? Left lobe, it is. Impending rupture, I told you it is. Failure to respond to medical therapy is. Abscess measuring 3.5 centimeters is not. It should be more than 5 centimeters abscess cavity. A patient with hydrated disease has water lily sign. We've discussed this. Water lily sign will be CE3A. We've discussed that water lily sign is going to be CE3A. So that is the correct answer here. It is CE3A. So which of the following incorrectly matches the score with the components? So MELD serum creatinine, it is included. In Child-Pugh bilirubin is included. In PELD INR is included. In MELD albumin is not a component. So albumin is not a component of model for end-stage liver disease score. So that brings us to the end of this module on benign liver disorders. The benign tumors I'm going to cover in the next module.